Good evening, and welcome to this webcast of the Methodist DeBakey Cardiovascular Journal. I'm Miguel Quinones. I'm the editor-in-chief of the journal. And this current issue that we're discussing today is on heart transplantation, 40 years later. And we chose this topic for the current issue of the journal for two reasons. One, we are celebrating 40 plus years of doing heart transplants at Houston Methodist. But in addition, it's a topic that has evolved a lot in the last 4 decades. And although heart transplantation is done in very specialized centers by experts who specialize in taking care of patients and surgeons that specialize in doing it, us as general cardiologists need to stay in touch with what's going on and learn more about the state of the art of the technology, where are we now with managing patients in general, what kind of patients we should be thinking of referring for heart transplantation, and importantly, the whole issue about availability of donors, which is an important topic that we will see today. I'm indebted greatly to Dr. Cindy Martin. She's the chief of the Division of Heart Failure here at Houston Methodist, sitting on my left. Thank you, Cindy. She did an amazing job as the guest editor, putting a lot of great authors that really wrote wonderful papers, very educational, and written in a way that us dummies, general cardiologists, could really learn about the whole topic. On a personal note, this is also a very close topic to my heart, given that I'm old enough to have been here in those early days in the 80s when Dr. DeBakey decided that it was time to restart heart transplantation at Methodist. And he called on one of my young colleagues to participate on that and help him with it. And that was Dr. Jim Young, who is joining us today. And at that time, Jim was a young cardiologist, as I am. He took over the job, and it actually changed his career. From then on, he became one of the leading authorities in heart failure and heart transplantation. So I'm delighted that Jim is joining us tonight, too. So Cindy, I put it on your hands.
Yeah.
Take us through this webcast and teach us a little more about heart transplants.
Thank you, Dr. Quinones. And, it really was an honor to be able to be guest editor for this journal in this particular, compilation of stuff to really kind of go from where we were in the past to where we're moving in the future of heart transplant. And for me, it was kind of a fun full circle moment because, I did my training in Dallas at UT Southwestern, and then I went to the University of Minnesota, which obviously where the training of Dr. Barnhart, who did the first heart transplant. But then to move here at Houston Methodist to come back to where it really was, again, so many of the surgical techniques were continuing to be modernized and move forward. It's kind of a full circle moment for me to kind of be a part of this. I'm also very indebted to all of their authors who helped us write this. We're just going to highlight a few of the articles today just in the sake of time, but it really, I agree with you, it's an all-star lineup of articles that were written for our issue, and I think it really does span the spectrum from history to the future of where we're moving forward. When we kind of step back and think about it, also to me was kind of awe-inspiring to realize that since we first started doing heart transplants in 1967, that it's estimated that we've done over 100,000 heart transplants in that time period. And of course, a lot of those, are even done more in our current era, and our success with those have increased, dramatically back from the initial days of heart transplant. But it really goes back to kind of, as they said some more, standing on the shoulders of giants to be able to do the things that we've been able to do. When we first, the journal starts, it's going to talk about, kind of give us a little history of transplant and setting the stage that Dr. Asrith Gua kind of goes back and really goes through. And I think it's a really fun place to start and kind of bring us into where we are and review from where we went. And then, one of the main questions, as you kind of pointed out, is who is a transplant candidate? Who should we look at for a transplant? How do we determine that? And us as heart failure physicians really depend on our general cardiology colleagues to help us identify those patients and identify them in a timely manner, because so many of the times, a lot of times when we're seeing these patients, they're so far advanced in their disease that we're also having to make these hard discussions with patients and these hard workups in a state of crisis, which is just makes it more difficult for everybody. And so was one of the things that we really explored, and Dr. Michelle Kittelson really highlights that in her article of like determining like who is a candidate for heart transplant and what does the transplant evaluation process look like.
As I was reading that article, it was really interesting that there was one slide she put of the 3 important areas. Today is exactly the same that we had in the 80s. That one thing has not changed.
Yeah.
Patient has to be very sick by a number of criteria. They have to have decent health, otherwise that we can manage that. And they have to have some level of capacity psychologically to manage the whole thing and support system.
Yeah.
And it's fascinating that that's exactly what we also were doing in the 80s when we started.
And unfortunately, Dr. Quinones, we still do kind of a terrible job of figuring out those sometimes. So, we make kind of assumptions for different things. And especially like you highlighted, when it comes about the psychosocial evaluation, unfortunately, there's a lot of work that's done that there's a lot of bias involved in that, and we've realized that it's and it's not intentional bias, but a lot of times people aren't referred because people feel like that they won't be able to handle some of these things, they don't have some of the support systems, or maybe they're not an appropriate candidate, when today, especially with the technology that we have, we do have options to be able to support these people and get them through that process. And so that's one of the the messages that I think Dr. Kittelson highlighted, and I would like to echo is we'd rather you send us, of the 10 patients you send us, that 9 of them either not be ready yet or maybe have some issues, than not get that one, in time for us to be able to look at that. So I think, walking through that article, I think was eye-opening.
So what the message you're giving is, if in doubt, refer.
Absolutely.
And let the experts then decide if the patient is or not.
Well,
rather than keep that patient from the opportunity of having a...
Yeah, and it also gives the patient some time to grasp that. Because, moving through this, I've never had a patient that's disappointed when I say, you don't need a heart transplant yet. But then letting them know stuff and be able to kind of wrap their head around stuff and walk through the process, to have their family and their social support and just be emotionally ready. Right. It's so much easier in that process when we have time to walk through that. Yeah. So 100% yes. When in doubt, refer.
One important comment to the audience: if you have any questions for us, feel free to text them to DeBakey at 37607.
But I think one of the things that that we still struggle with and focus with, even though we're probably not getting all the patients referred who would benefit from that, we still are at a situation where there's way more people who are on the transplant list or being evaluated for transplant than we have donors available to use. But there's really been some huge strides made in that, and I'm really honored that Dr. Kelly Schlendorf was able to join us today to be able to give us some insight into some of the things that we've recently been able to do of expanding the donor pool for heart transplantation. So Kelly, tell us a little bit about some of the things that you highlighted in your article and some of the options that we've been able to move forward in that arena.
Sure. Thanks, Cindy, and thanks to both of you for the opportunity to contribute to this important piece and to be here for this webcast. As you mentioned, at any given time, there are probably anywhere from about 1.5 to 2 times the number of patients who need a heart transplant as there are heart transplants available. And so my co-author, Dr. Toro, and I had the opportunity to describe some of the strategies that we've used really over the past 5 to 10 years to expand the donor pool and try to safely take more patients who are eligible for transplant to transplant. The 2 biggest strategies, I think, over the past 10 years that we highlighted in the article are, first, transplantation of hearts from donors who are actively infected with hepatitis C virus, and second, more impactful in recent years, transplantation of hearts from donors after circulatory death, or DCD. I think both of these are really nice examples of ways in which advances in scientific discovery and innovation have allowed us to expand the donor pool. So in the case of hearts from hepatitis C infected donors, it was really the advent of newer and better therapies for treatment of hepatitis C that became available about 10 years ago that allowed the transplant community to reconsider the use of these organs for our recipients. And what we know nowadays is that using these therapies, our patients, when they receive hearts from hepatitis C infected donors, will go on to develop hepatitis C virus, but that it's very curable with these newer therapies, and that the therapies themselves are very well tolerated. And I think in calendar year 2024, I think I saw one estimate that about 10% of all transplants performed in the United States were from were from donors who were infected with hepatitis C. And then the second strategy has been DCD heart donation. The DCD donor, unlike the brain dead donor, is one in whom the heart has stopped beating for some period of time before organ recovery commences. And the concern, of course, is that during that time, those hearts are subjected to a period of what we often refer to as warm ischemia, during which myocardial injury is known to occur. And so it's been advances in the way that we think about recovering hearts and preserving them during transport from the donor hospital to the recipient hospital that have allowed us to consider these hearts. And what we found, since a lot of DCD programs have popped up across the country, is that outcomes in recipients of DCD hearts are non-inferior to those of recipients of brain dead hearts. And in some cases, we think they may even be better. So both very important strategies in helping us.
Could you, for the benefit of us general cardiologists, give us a couple of, maybe one or two scenarios that are typical of doing that type of donor procurement?
Well, Dr. Akay could probably speak to this better than I can as a surgeon, but I'll tell you that generally speaking, when it comes to recovery of a DCD heart or a donor after circulatory death heart, there are two different strategies that are typically, one of two different strategies that are typically used. One is referred to as direct procurement and preservation, whereby the heart is excised from the donor and then essentially preserved using what we call ex vivo machine perfusion, so a portable device that perfuses the heart using a warm perfusate during transport from the donor hospital to the recipient hospital. The second method is referred to as...
Sorry to interrupt, Kelly. I kind of think about that as like a little incubator for the heart.
Yeah.
So they put it in this little box, this little incubator, and it pumps blood, and it actually beats, and they can see
so
it.
I'm assuming that these are people who, they're not brain dead, but they're terminal, and the family and everybody has already agreed that you would disconnect them from whatever support they had.
Yes.
Is that the classic
right.
clinical scenario?
Yeah.
Yes, I think sometimes the distinction between DBD and DCD can be confusing, but in both cases, the donor has suffered some kind of devastating neurologic injury that is thought to be irreversible. The DCD donor doesn't meet formal brain death criteria, like the brain dead donor does.
Yeah.
But I think that's a great point that you bring up, Dr. Quinones, because that's brought up a couple of times. These are patients who are neurologically devastated.
Yeah.
And they are not going to, and it's been determined that, they're not going to have meaningful neurologic recovery. And their family has already made that decision before the transplant option even comes in. That this is not something that they would not choose to live this way. And so that decision is made even before before the transplant option comes in, but gives, again, it does expand those that particular group to once again help maybe make something positive out of a very tragic situation.
Yep.
So Kelly, sorry to interrupt you. You're telling us a little bit more about the other option for DCD.
Yeah. So the second method by which these organs are often recovered is referred to as normothermic regional perfusion, and NRP. And in this method, the donor heart is actually reanimated in situ. It's reanimated within the donor's body. Prior to then later being excised and either placed on ice or placed in some kind of controlled hypothermic environment using a number of different devices that are now being investigated. And I will say that some centers exclusively use one of those techniques, some centers use the other, some centers use both. And there's a fair amount of data that's been published over the past few years suggesting that both of those recovery techniques yield very good outcomes after transplant.
So Kelly, maybe one other thing, I know back when we first started, there was some concern of maybe the hepatitis C infection could create issues for the donor heart and may impact outcomes moving forward. But I know recent data has shown that maybe that's not the case. So maybe, again, just updating some of our general cardiology groups, because back in the beginning, especially back, when I did my training, there was a concern about viral infections like CMV and other things actually being detrimental.
Yeah, I think that's a great question. And in the early 2000s, when these hearts were sometimes being used, the outcomes were very poor. They were patients who were recipients of these hearts had increased rates of a common complication after transplant called cardiac allograft vasculopathy, and that they had higher rates of mortality. And that was in part because hepatitis C using the older treatments just was not easily treatable, and the treatments weren't well tolerated in the transplant population. So as I'd mentioned earlier, the newer treatments are much better tolerated and very effective in treating hepatitis C and in curing hepatitis C. And what our center and a number of other centers have shown is that recipients of these hearts who go on to be treated and cured of their hepatitis C virus really have excellent outcomes thereafter. There doesn't seem to be any significant signal for an increased rate of rejection of the heart or for other complications like graft vasculopathy.
Just amazing, where we've come and to be able to open these things up. And
Yeah, I would have thought that in the early days, putting an infected heart in a patient would have almost been malpractice. And now it's common practice.
Yeah.
It's really an
it's funny.
amazing technological. It's incredible, really.
Yeah.
It is.
Yeah.
What about HIV? I think in your paper you talked a little bit also about the HIV situation.
HIV hearts are being considered specifically for patients on the wait list who are infected with HIV,
Yes.
and that's under what's referred to as the HOPE Act. And so there's a growing experience in doing that, and the feeling is that specifically for waitlisted candidates with HIV infection, these hearts could potentially be a real source of organs for them.
That's fantastic.
yeah.
Yeah.
Yeah, just an amazing opportunity to be able to, open up more candidates, for donor transplant, for organ transplantation, to be able to expand that gift of life for other patients. And, I think this is another topic where we really also have to, really, I guess, respect and be appreciative of the journey, the leap of faith that our patients and their families are willing to take for some of these options to move forward.
Absolutely.
Because not only in transplantation, but I can imagine the first conversation that you have with some of these people about using these alternative strategies, and so it's also always, I think it's always awe-inspiring to me to be able to what our patients and their families are able to do as well.
I suspect that that's one area that AI may not be able to replace us.
This is true. Job security. All right. Well, Kelly, thanks so much. Like I said, Dr. Schlendorf and Dr. Toro's article really highlights a lot of these fun things, and I really, really recommend, looking at that and kind of seeing those opportunities that have been able to move forward. I think moving forward a little bit, when we talk about, other situations where there's been huge advances and also an unmet need, really speaks to our patients with congenital heart disease.
Yep.
As we know now, even for it's almost been 20 years, hard to believe, but in 2007, for the first time, there was more adults with congenital heart disease than pediatric patients with congenital heart disease because of the advances that have come in surgical techniques and other medical therapies. And so although that has been an amazing advancement, it has brought with it other complications and challenges in caring for these patients, especially as they develop end-stage disease and end-stage heart failure, because with their abnormal circulations that they have come challenges where there have been stresses on other organs.
Right.
And so really our adult congenital heart disease patient population has kind of driven, at least now in our current era, probably a lot of our multi-organ transplantation. And so Dr. Yousefzai and colleagues really kind of highlighted this in their journal article of addressing that. And so, Rayan, tell us a little bit about some of the things, that was highlighted in the article when we talk about multi-organ transplant and specifically in our adult congenital patient population.
Yeah, thank you, Dr. Martin, Dr. Quinones, for the opportunity to contribute in this journal, and thank you for having me here. So this has been kind of my passion for the last few years about adult congenital transplant patients. And why do we talk about these patients? There's a exponential growth of the adult congenital patients that are meeting to adulthood right now after the improvement of surgical techniques that they're having when they were children. So this population has been growing from 300,000 in the 1970s. Now we are up to 2 million people with the adult congenital. And heart failure, unfortunately, is a leading cause of mortality and hospitalization for this patient. And heart transplant maybe the only option for one of these patients who there's no other intervention, or the intervention are too high risk for this patient. However, there's a large gap between those who will benefit from the transplant and who actually be able to receive these therapy. In this article, we are highlighting some of the challenges, some of the unique things that we think about this patient. And some of the challenges start even from the beginning, how to recognize advanced heart failure patient in this population. These are the patients who live with this condition from their children, and sometimes hard for them to express and have the symptoms. So the recognition could be challenging for this patient. Limited access.
So Rayan, you bring up a great point when we talk about, even figuring out heart failure in these adult congenital patient populations. There's really no consensus on how you define heart failure in that, group. And so much less, even figuring out who has advanced heart failure in these situations just causes a huge challenge.
Even the presentation is not the typical presentation of an ischemic guy with a EF of 20 that is in heart failure.
Exactly. And there's not even a uniform definition that's agreed upon by everybody of what is true heart failure in adult congenital patient populations, because it's so frequently as a spectrum, depending on what they were, kind of what their particular condition is.
I hear multiple times from the patient after a transplant, they'll tell me, I didn't know that you can feel like this without short of breath doing activities. Yeah. So you just don't know what that is. So that's why it makes it so difficult to recognize the symptoms in adult congenital patient. The other challenges that we face is a limiting access. There's a small number of the patients with adult congenital, they cared by adult congenital specialists, let alone to access to a center who will be able to do the transplantation. And of course, the need for multi-organ transplantation. There are a lot of extra cardiac involvement, from liver involvement in the Fontan-associated liver disease that the patient might need heart and liver transplant. About 50% of these patients, they do have renal dysfunction, who they need a thorough assessment for the need for simultaneous heart and kidney transplant for this patient. The lung disease, including the pulmonary hypertension, including the unrepaired shunt for this patient, or atrioventricular venous malformation, or restricted lung disease that may necessitate this patient for having a heart and double lung transplant versus heart transplant alone. And we also highlight some of the unique aspects of this patient, that what we think when we evaluate this patient. For example, there's a lot of immunological challenges. These patients have reduced immune cells and maturity. Some of these patients have thymectomy, which is done at the time of the surgery, that increase their risk of infection with the immunosuppression. And also the sensitization that these patients have. These patients have multiple blood products, they have multiple surgeries. They have a homograft that increase their sensitization, which makes it challenging for find the right donor for this patient, and also using a technique such as desensitization for this patient to increase their opportunity for get transplant in a timely manner. We really rely on the multimodality imaging for planning. There's a lot of planning for this patient that happens before transplantation. These patients have surgeries, there's a lot of scars and adhesion, so determine the planning for re-entry strategy by the surgeon, the access planning, need for reconstruction, that what needs to be reconstructed during the operation. And there's some of these patients that have extensive collaterals that needs to be assessed for the surgeon to be able to enter the chest and safely, and also if there's a need for embolization, some of these collaterals to mitigate risk of bleeding at the time of the transplantation. And also there's a lot of planning at the time of the procurement. Our surgeons, after reviewing this multi-imaging, if they need an extra vessel at the time of the procurement, or for example, anonymous weight for the persistent left SVC patient, this all needs to be planned by this multimodality imaging and discussion before surgery. The surgical consideration is other important part that we consider these patients. So most of these patients, they have multiple surgeries in the past. About 80% of this patient have at least one, and 50% have the multiple sternotomy before transplant. So the goal of the surgeon is to establish a safe re-entry, establish a secure peripheral cannulation, and also plan the extensive anatomical reconstruction before transplantation. And there's also this article highlights some of the specific physiology and consideration that we think about at the time of the transplant. For example, one of the highest complexity and highest risk patients are Fontan patients. There's a lot of discussion about the reconstruction planning, about the liver. Most of these patients have a Fontan liver-associated disease and cirrhosis. Who are the right patients who will benefit from a heart alone? Who are the patients who will benefit from a heart and liver transplant? And how to manage these patients before or after surgery? And also, there's a consideration for the heart double lung. So some of these patients have a severe pulmonary arterial hypertension or Eisenmenger physiology that would need heart double lung transplant, or they have some restrictive lung disease because of where the anatomy is, then they might need specific consideration for a heart versus heart double lung.
Can I ask a quick question? Why is it double lung, and why isn't there a single lung won't do the trick?
Absolutely, that's a good question, Dr. Quinones. So the patient who have severe arterial pulmonary hypertension, they will need double lung, because most of the time the single lung, there's still the etiology of the pulmonary hypertension. The other lung, it can still have a significant pulmonary arterial hypertension, which will cause a significant right heart failure of the new transplanted heart. Yeah. So anybody that has a higher pulmonary pressures, they usually the practices to the heart double lung to protect the new right side of the heart from pulmonary arterial hypertension.
Yeah. And then sometimes it's also anatomical. You know, some of the issues of being able to transplant just a single lung in some of these anatomies are...
It's easier actually to do too.
Absolutely, because when you're trying to match abnormal to normal, they don't kind of fit anymore. It's kind of like, you know, round hole, square peg sometimes of some of these situations. So, you know, Rayan, I'm going to say, you know, as much as, you know, these sounds great. Now, if our general cardiologists weren't worried before, I think they're probably now terrified of adult congenital, you know, multi-organ transplants. But maybe tell us a little bit, you know, about the survival in these patients, but of why we shouldn't be just, you know, writing them off, and why we should be kind of pushing to explore some of these options for them.
Absolutely. So, I mean, two reasons. One, I think that this patient, as we said, so due to the access or recognition, the advanced heart failure, they might get referred and evaluated later. So if the patient get referred and evaluated in a timely manner to have the transplant before developing some of the complications associated, for example, PLE or severe pulmonary hypertension, they would do better. Second, this patient, what they have for them, they're younger. And if you look at the survival, even though there's a complexity of the perioperative increased risk, but if you look at the long-time survival of this patient, they do actually better. They survive, they live longer than most of other regular transplanted patients with the ischemic cardiomyopathy or dilated cardiomyopathy. So I think there's definitely a silver line here that if this patient gets referred and get under the therapy on the timely manner, and they survive initial high-risk operation over a long period of time, they do actually pretty good. Yeah,
and that's one of the things that that was really, refreshing and I think important to see in your article, is that this really is the high-risk, high-reward, patient population of, yes, there's that increased risk up front, but as Dr. Yousefzai said, they actually tend to have the best benefit and the longest survival afterwards if they survive that first year. Yeah. And so I think it's really, again, I know we say, referral, but in this patient population, I think it really highlights that as well, that being able to get them sooner so they're at lower risk of the higher risk spectrum. They will never be low risk. And I think we always have to acknowledge this. And I also think that, what was also facilitated is the understanding that these patients do need subspecialty centers, because the amount of the multidisciplinary team that's needed to take care of these patients is high. And so I think being able to, for our general cardiologists to find that partner, to find that center that you can partner with to have that. And it doesn't necessarily have to be a partner that can take them all the way to transplant, but, getting them into that adult congenital specialized care to help them on that pathway. So thank you, Rayan. Thanks for highlighting all the work that you did. I know you tackled a big topic on that multi-organ transplant and adult congenital heart disease in one article. So thanks for bringing that into focus for us. And then kind of shifting over to our surgical colleagues, it's my pleasure to have Dr. Mehmet Akay joining us today and kind of talking a little bit about the evolution of heart transplant. But before we go there, I have to just ask you, Hakan, just from a non-surgeon standpoint, I think doing a heart transplant and then seeing that work has to be an amazing experience. Tell us a little bit about that, and then we can jump into some of the surgical techniques.
And before he does that, since again, I had the privilege of being seeing the very first one we did with Dr. Young back in '84, I have to say, seeing a heart come out, an empty chest, and a new heart come in, at that time for me was a mystical experience. Really was. And I have to suspect that even today, for many of the surgeons, that moment has to still have a little bit of a little in your blood when you're doing it. I know it becomes routine eventually. Even everything that we do in life becomes routine, but that moment is still a very special moment. You're taking a heart out, the chest is empty, and then you bring another heart in and you put it in. It has to hit you in a very unique way, even though it's a routine nowadays.
And Mike, in that essay that I wrote about a little bit of the history and the evolution, I titled it A Sacred Adventure. And to your point, the picture that was in the article was our second or third transplant that we had done. DeBakey had asked me to be in the operating room during all the donor, we used to call it harvest, but donor procurement and transplant procedures. And that picture was taken at the head of the table. I was taking pictures. They had a photographer from Methodist Hospital that was taking pictures, and it's this lifting of the procured heart up. And what it struck me as, and for any Catholics in the audience, it struck me as seeing a host being elevated during the consecration in a Catholic Mass. And when you couple this issue of brain death and now CDC death with the donation of that organ, then with the technology that is there to reanimate that heart, it really is an astounding thing, in my opinion, to see. And the hundreds of transplants that I've been involved with, thousands of transplants, and a lot of involvement in the actual operating room, which is a little odd for a cardiologist, I'll admit, but we did play a role. It really is a sacred adventure.
Thank you, Jim. Yeah. All right, Dr. Akay, you're on.
Yes. To that beat you mentioned, Dr. Quinones, yes. I mean, in conventional cardiac surgery, we stop the heart and then, do the bypass or change the valve or do the correction, and then we remove the clamp and heart starts to beat. But it's not the same. I think it's not the same because of the philosophical, mystical, and sacred part, and then somebody else's gift and is right there and giving in another opportunity in life to our patients. That is the really important part of the heart transplantation, and I love it. And I really thank Dr. Martin and you to make me part of this project and writing the article, because first of all, I love about the heart surgery's historical part, and that was a wonderful pleasure for me to write this with the guidance of my mentor who taught me how to do the heart transplant, with Dr. Bud Frazier, and it was a big honor. Thank you.
So, Khan, tell us a little bit about with talking with Dr. Frazier and kind of as you went through the history, a little bit of how the surgical thing, the evolution a little bit of to where we are today.
It is truly amazing that is, I call it, as you in the beginning in the mentions, things not change, they're, It has not changed, absolutely. And I call the founding fathers, that Dr. Shamway, and you would be very proud, University of Minnesota, Professor Wagiston, service, and all the lab work is done with Dr. Shamway is still the same for the cardiac donor cardiectomy. I mean, the absolutely what he described, how to preserve, is be doing the same. Nothing is changing that. And then the other founding fathers is the Vladimir Demikov, which is, we didn't know, Western world didn't know much, but later on in late 60s, the article came, his work in 1950s with the intrathoracic transplant, which is the heart, lung, and heart and lung transplantation. What he described, we still do the same the principles with the time, with the implantation techniques, with the of course it's evaluated and some it's modified techniques to deal with the complication and long-term problems, but the principle is exactly the same. And it is evolution, but not much change. And what's fascinating is that the founding fathers is lab work on animals is reflected, still be doing basically the same thing, and with some modifications. First is the cardiectomy is the same as I mentioned, and then Dr. Shamway described the biatrial technique, which Dr. Christian Barnard applied on which was also DCD heart transplantation in Cape Town in South Africa. And we kept going with that technique long time, and until 1990s, where the idea came that we start to have a lot of right atrial rhythm problems, tricuspid valve problems, and all those things. And then because the heart is hanging down in the pericardial cavity with that portion, because there's extensions of the right atrial wall giving not putting the heart down in that, and just correcting that with the bicable technique came up, and that actually reduce those problems, that right atrial rhythm problem, originated rhythm problems, and the tricuspid valve problems. And we kept going with that for until 2000s. And then in the article also with another evaluation came from the Japan, just doing the modified bicable technique, which is I still do the regular bicable technique, but it got a lot of acceptance, using the back wall as a pillar, and the anastomotic technique, which reduced the kinking of the superior vena cava, inferior cava, or just the bleeding problems as well. And then between that time, another founding father, Dr. Mehmet Yakup, he's a brilliant surgeon as well. He came up with a because when we're doing the transplant, we use the cuff, left atrial cuff, and put another cuff on top of that, which is not very two section, we putting it together. He said that why we don't put just eliminate these left atrial cuff and put the pulmonary veins and do the anastomosis, but it didn't gain so much popularity because it's complex. You're doing the pulmonary vein anastomosis, and I think it died. I never seen that technique is being used. Probably it's for pediatric patients, and during the late 90s, 80s, early 80s, Dr. Yakup described it, but never gained a popularity. And then another technique is died, which is brilliant, which is also Christian Barnard's contribution, is a heterotopic heart transplantation. The heterotopic heart transplantation is actually incredible. I've seen patients with that, and to be honest with you, even it is just today's left ventricular assist devices, and that was used during for the patient with the high pulmonary artery pressures, high TPGs, and it was used as a biological left ventricular assist devices. But
We-
with the new
So
Yeah, we did a good share of them when we did not have good LVADs.
Yeah.
And
Yes.
there's a lot of fun echoes with it because you have an outpatient coming in for a checkup and you look at their heart and it's not moving.
Yeah.
Because
Correct.
there's another heart.
yeah, so maybe tell us a little bit, but for those people who may not be as familiar, the difference between the orthotopic heart transplant and the heterotopic heart transplant. So
Piggy valve, the piggy heart we used to call it.
correct, PVUL, and there are still people that lives with that, and when they walk into the emergency rooms or the doctor offices, they are like amazing phone calls that you will receive from those places. But it is exact the using the piggyback. Actually, you putting the donor heart onto the left side of the chest, not into the pericardium, and making the left arterial connections and using conduits and extending the pulmonary artery and putting the aorta onto the side of the aorta as you're anastomosing, and you're putting a conduit, the artificial vessel between the donor PA artery, because it will not reach, right? Because it's you putting it in the side, so you have to make some extensions, and it's basically using like a assist device, left ventricular assist device. But now I don't think anybody does that anymore. And it's to be honest with you, I have not seen one done. Even Dr. Frazier loved that, and he did a lot of those. But my time didn't reach that time. Like cholecystectomy.
One question I wanted to
Yes, sir.
ask you. As an echocardiographer, I have seen thousands of heart transplant echoes, and for many years, the classic heart transplant echo had a huge right and left atrium, because basically we're two atriums connected.
Correct.
More recently now, we're seeing the transplant patients coming in with smaller atriums. So two questions. Number one, what is the technique that has resulted now in the left atrium and right atrium being smaller? And number two, has that had any real improvement in outcomes? Do the patients with a smaller appearing atrium have less arrhythmias or in any way a better outcome?
So recently we doing the bicable technique. The right atrium is the normal. There is no remnant of the right atrium at all. So it's the cavity is the normal right atrium. So the left atrium, it's smaller is better actually, because like that is the surgeon's preference. But I don't know if it's one thing that doing the anastomosis when you're doing endocardium to endocardium is very important, which is those might be some initiating some clot formation in the left atrium, which is but other than having two cavity with a huge connection on the left atrial side, I don't know if there is any really has impact on the outcomes too much. For arrhythmia, it's not very physiologic.
For the audience out there,
you try to make it really small cough. I mean,
for the audience out there,
good.
if you are watching and you do get heart transplant patients come by your practice, the old technique was very easy. You will see those huge atriums with clearly you could see the point of anastomosis. Now a patient may come in with a heart transplant, they may look like anyone else. So you have to be a little more sure about why this scar is in the chest.
very true.
Yes.
Yeah.
Well, the other problem with the recovery of a heart, when you're doing when you're taking more of the inferior vena cava, is the challenge in the operating room during organ procurement and the wars that develop between the liver transplant surgeon and the heart transplant surgeon. And I can remember seeing the very first one in one of DeBakey's operating rooms when we were attempting to do that type of procedure. I don't know if there's still that war that's going on.
Oh, yes.
It is actually, but we are gentlemen, so we just make the like this line, is it okay? And we have like a consensus, and then even sometimes I hand it over to the Caesar. So there are sometimes people complains always. I just hand it over to Caesar and make them
So less elbow.
correct.
Okay.
But I
all right.
heard really bad words, and then like bad communication. But we try to be gentlemen, so we don't do that.
Yeah, very good. Well, thanks, Akay. It's great to kind of be able to revisit some of those, and I think your article really walks us through kind of the stepwise process, like you said, truly from research to application. And I think sometimes that we
That is
forget.
fascinating.
Yeah, that we forget.
And also, I really want to say something about Vladimir Demikov, who is the father of also coronary artery bypass grafting. He is the one in late 50s. He did a lima to LA anastomosis, and so it's. But we didn't know. We learned it way later, after 20 years later, after his work is done. So those are the founding fathers. I mean, the University of Minnesota, Wagenstein's. The pupils, Lily Hyde, Dr. Shamway, all those, their lab work today is foundation for what we do, and it's incredible.
Well, thank you so much. You all have heard Dr. Young mention a couple of things, so I'm going to ask on him now to kind of end this for us, giving us a perspective of the progress in the whole arena of heart transplant, particularly Jim. What do you think is the future? We keep talking now about going around when you have bad heart failure and getting a little pig to donate a heart for you. So is this something that it really is the future? Are we going to eventually be able to have these genetically processed animals to donate hearts to solve a lot of the donor problems? How you have been privileged to have been in this field from the beginning to where we are now. What are your thoughts?
I think it's vastly more likely that we are going to have mechanical circulatory support devices that will be better suited for the physiology of the heart, longer lasting, and will maintain patients better than pig hearts, as you put it. Last year was an eventful year because there were several porcine manipulated hearts that had been implanted, and they all failed. The area that has had the most success with porcine grafts has been in the kidney. But just last week, in the New England Journal of Medicine, the latest and longest living porcine kidney transplant died after 12 months. And so it's an unbelievably complicated system to do the genetic manipulation to allow the porcine heart or porcine liver or porcine kidney to not be rejected. And if you read the articles, there hasn't been very much success with drugs, the usual drugs that we would use in any sort of allograft transplantation. There hasn't been the same success in the porcine model. So, Mike, I hate to say this, but I don't think in your or my lifetime we're going to see it. I think it's just a road too far to get through. But there is an incredible amount of work being done still in the laboratories to try to figure it all out. But it's an absolute massive sort of thing.
So right now you're more.
And I mentioned
you're more optimistic towards the totally mechanical heart than.
Yeah.
yes.
Yeah.
So maybe you're still on
much.
Yeah, you're still in the boat from. I remember Sarah Shumway used to tell me that her dad, Norm Shumway, used to say that xenotransplantation is the future and will always be the future.
And
But
just
maybe
around
we-
the corner, or always just around the corner.
Yeah, but maybe, you
Norm
know-
Shumway was
Yeah.
great with that comment.
But
yes,
yeah, I think we'll go back to that a little bit. I do think, I think that we're still the future there, but I do think there's been this amazing work that's been moving forward in some of that. And I think Dr. Gary and his team kind of highlight some of those things in the article about some of the things that are moving forward in xenotransplantation and allogeneic and exogenic options for some of these things. So I do think that I completely agree. I think that we're not right around the corner, but I'm optimistic that the road will lead there eventually.
To which
To doing, like, using other options, either xenotransplant or allogeneic, or even, more engineered organs of those things.
So what about the total heart?
Yeah.
That has been
Right.
now also
Yeah.
the dream for decades. Is that going to happen?
Well, Mike will remember way back when we started the programs, we were very bullish on utilizing some of the devices that DeBakey first made. The first total artificial heart really came out of DeBakey's lab. Fascinating story. But what has evolved are smaller units, continuous flow units, and the Bivacor heart, which our next door neighbors, or your next door neighbors over at St. Luke's, have worked with Bud Fraser and some people from New Zealand or Australia. No, New Zealand. Australia, yeah, and it's in trial right now. I don't know if Methodist is using it, but Bud has set up an international trial of Bivacor, and it's a very uniquely designed kind of continuous flow pulsatile a heart, which is small, mechanical, embedded, and can use transcutaneous driving systems. We have one at the Cleveland Clinic that is similar to it. It's been in animals now for several years, and there are other places around the world that are focusing on mechanical hearts, and I'm predicting that we're going to see that for cardiac work before we're going to see porcine or other animal transplants. That's just my opinion.
So the future.
I agree with Dr. Young. I mean, especially Dr. Fraser always is very strong about his emotions and stuff, but he makes his statements and he's always right on that. He says every one of you will put this device in a large meeting room talking to the surgeons, and I think that it's the xenotransplantation is just like what our journey. We manage the cellular rejection, which is transplantation also the same. They managed the cellular rejection, but the problem is humoral rejection, and that's what's causing the graft to die. And I think that is gonna be a long journey, more than mechanical. Hopefully, the total artificial heart.
Well, thank you so much. We have about 5 minutes left, and we don't see any questions for us from the audience. So, Cindy, one of the topics we could not have today because the author could not participate, but I think it's a very important topic, is one of the late complications of transplant, which is the coronary artery disease.
Yeah.
Can you give us a little brief summary of that article, because I think it was very well written and very educational too.
Yeah, so in that article, Dr. Monica Colvin and her colleagues really talk about chronic allograft vasculopathy, which really is, unfortunately, kind of the most common reason that grafts fail late. We're learning some more of those things. We've learned that it's most likely an immune-mediated process. So you can kind of think of as chronic late rejection, and and it's just manifests much later. Some earlier work went in, but some of the new immunosuppression regimens, specifically using the group of medications called the mTOR inhibitors. If we used to wait to use those until we started seeing evidence of transplant vasculopathy and kind of switching over, and we had some success, but not as much. But now a lot of the data is showing if we initiate these medications very early in transplant, that it does really reduce the risk of the transplant vasculopathy, sometimes at the risk of a little bit of rejection, but the overall outcomes have been shown to be better with early utilization of the mTOR inhibitors. And I think it's one of the things that, I think that we all learn in life, right? The more you know, the more you understand what you don't know.
Right.
And I think the immune system is a classic educator about that.
Yeah.
The more we learn about it, the more we learn the challenges that come with it. But there has been a good bit of, I think, progress made in transplant vasculopathy. We talk, and in the article they talk about even how you define transplant vasculopathy, some of the imaging things to look at it. But I think, the bigger tool in the armamentarium right now is really the early use of the mTOR inhibitors.
I was fascinated in the article. I didn't know this part, that traditional management of risk factors is also done.
Yes.
And of course we use the statins, but in the typical ischemic patient nowadays we want that LDL to be 50. And it was interesting that if you bring LDL down to 100 or 90 to 100, you clearly see a signal of benefit, but then continuing to go further down apparently hasn't really shown much other benefit, indicating that, of course, it's a multifactorial phenomenon where the traditional cholesterol plays maybe one role, but not the big role like in the common ischemic patient.
Absolutely.
Very
and
interesting.
Just as you said, and it's interesting, the statins probably have some anti-inflammatory effect, even in that chronic rejection part, but not just, the kind of the panacea results that we see in some of the others.
Well, Dr. Young, you're the most elderly person here with the expertise in the topic, although I'm a little older than you. You want to close for us, giving us your final thoughts? We have about 3 minutes.
Yeah, I think that the bottom line is organ transplantation generally has made dramatic impacts in patients with end-stage disease processes, and that working together with our other transplant physicians, transplant surgeons, to really understand better the immunologic issues will bring new drugs, new approaches. And then, as you heard, I'm pretty bullish on the mechanical aspect of things. And so I think transplantation has a bright future. It's now got a very long and well-developed history. And so I think the future is going to be very bright for all sorts of patients with end-stage organ disease. And so I'm pretty bullish on where we're going, and also from where we've come from. We've seen, I think, dramatic improvements and changes. You just look at the societies that have come up. I remember when we were starting, there really was no societies. There really was no focus on transplantation, and now they're huge and worldwide. So thanks for letting me close things up here.
Thank you so much, and we're going to have Dr. Martin give us some final thoughts too.
Yeah, and I think, as you just said, Dr. Young, I think you highlight a lot of things, and we didn't get to talk today, about, like you said, the immunosuppression management in heart transplant, and that really has changed, and there's a lot of drugs on the horizon that, as you said, we really learned from our other transplant colleagues, specifically our renal transplant colleagues and our liver transplant colleagues, because just the numbers of those organs gives us more availability for us to learn from. And I think the other thing that we didn't talk about, but is a process that we continue to work on, is really on the policy and oversight of cardiac transplantation, of looking at how we manage the distribution of organs, how do we try to optimize that and create, more uniform availability and management and those things. And so I think Dr. Shelley Hall and her colleagues actually looked at, that article. And as I mentioned before, with the immunosuppression management, Dr. Melina Habal and her colleagues look at that. So I really encourage people to go and kind of take a look, because it really is kind of from A to B down to even the future of the transplantation with this issue.
So I want to finish with 2 important points. Number 1, please go and read the articles because there's a lot of wonderful education there for all of us. Number 2, if you take home one message, take home the following message. If in doubt with your patient, refer them early to the transplant experts and let them evaluate the patient. They may send it back to you saying, we like to see this patient once a year, he's still not ready, but create that relation rather than wait too late when the patient is already in a deathbed.
Yeah.
Time is up. I really want to thank everybody for a wonderful participation, particularly Dr. Martin. You're a pro. We need to have you here more often. And good night to all of you. Thank you.